the jugular venous pressure. Right? First, we'll talk about why we measure it. We measure it because it represents the pressure in the right atrium or the central venous pressure, and that is why we measure it. Next, where we measure it? We measure it in the right internal jugular vein. Okay. Why internal jugular? Because there are two big veins in the neck vein, the internal jugular and the external jugular. But the external jugular is tortuous and it traverses the fascia, so it can get obstructed. It can get compressed, it can get kinked, so it can get obstructed. So that is why we prefer the internal jugular vein. Also, it can also be said that internal jugular vein drains more directly and is more in line to the superior vena cava and the right atrium. Okay, so that is why we prefer the internal jugular vein. So where is the internal jugular vein located?
Sternal stenoid muscle lateral side.
Yeah, so just medial. Okay, so just medial to the sternocleidomastoid muscle. So it runs just medial to the sternocleidomastoid muscle, and it lies between the two heads of the sternocleidomastoid, the sternal head and the clavicular head. Between those two heads, it passes and then goes into the chest. Okay, so this is where we need to inspect for it. So that was about the location where we inspect. So next we'll talk about how we inspect it. So first we need to know about jugular venous pulsation. Okay, so these are two different terms, jugular venous pulsation and jugular venous pressure. So jugular venous pulsation stands for the pulsating movement of the jugular vein, internal jugular vein. So we need to know that the internal jugular vein has pulsating movements. Okay, and there is a specific waveform, ACV, you might know about it, right? So we won't talk too much about the waveform, because to visualize the waveform we need to plot a graph. The graph is plotted with the help of a catheter measurement. So we need to catheterize the vein to plot the graph, to plot the accurate graph of the waveform. It's hard to interpret the waveform just on the basis of inspection of the vein. Okay, so but we need to note the topmost point of the pulsation. Okay, so we will note the topmost point of the pulsation of the internal jugular vein. Okay, and once we note the topmost point, what we will do is we will determine the vertical height from the topmost point to the sternal angle. Yes, exactly. So the sternal angle is a bony prominence.
It has to be the clavicle.
So there is a bony prominence at the junction of manubrium of sternum and the body of the sternum. Okay, so this bony prominence is the sternal angle. We will measure the vertical height from the topmost point of the pulsation to the sternal angle. Okay, and next we need to know that the vertical height from the sternal angle to the right atrium
5 centimeters.
is 5 centimeters exactly. So once we know that, we can then calculate the vertical height from the topmost point of the pulsation to the right atrium. Okay, so we need to understand that this vertical height that we measure is the vertical height of the column of blood in the vein. So this vertical height of column of blood in the vein represents the pressure in the right atrium. Okay, so that is all about the theory. Now we will demonstrate how we do it. Okay, so first the prerequisites. The instruments that we need are 2 long scales and a torchlight, or we can also use a long card and a scale. Okay, so one of these scales needs to be long. Okay, and then we need a torchlight. So after we fulfill all the prerequisites, including consent from the patient, then we will ensure adequate exposure. Okay, so the necks will be completely exposed. So it's preferable to not have clothes with collars, but we will make a compromise here. Okay, so then the positioning of the patient is important as well. So the patient's upper body till the waist should make an angle of 45 degrees with the horizontal. Okay, so that is about the positioning. Okay, there are certain situations in which the positioning will be slightly different. We'll talk about that a little bit later on, but for most of the cases we will maintain 45 degrees angle of the upper body of the patient with the horizontal, and this is to ensure that the pulsation is visualized in the neck of the patient. Okay. Then the patient's head should be placed on a pillow. They should be rested comfortably on the pillow to ensure that the neck muscles are not contracted and the neck muscles are relaxed. Okay. So next, the patient's head should be turned slightly towards the left. Okay. So to visualize the right side of the neck. Okay. So after we turn the patient, then we will inspect for the upper point of the pulsation of the internal jugular vein. Okay. Sometimes it can be difficult and we might need to shine a torchlight. Okay. This should have been a torchlight. Okay. So we will shine a torchlight tangentially over the neck. Okay. So we need to shine the torchlight tangentially over the neck, and it should be oblique to the long axis of the patient's body. Okay. So this is how we shine the torchlight. And next, we need to differentiate this internal jugular vein pulsations from the pulsations of the carotid artery. Okay, so there are a few points that will help us differentiate, but for now what we can do to make it easier for us is we can use our right hand to palpate the left carotid artery. Okay, we are inspecting the right internal jugular vein and at the same time palpating the
left carotid.
Okay.
Internal carotid.
Yeah, so we are palpating the left carotid artery and at the same time inspecting the right internal jugular vein. We are palpating the left carotid artery and at the same time inspecting the right internal jugular vein to help us differentiate between the carotid pulsations and the jugular venous pulsations. Okay, so after this much it will be easy for us to inspect the jugular venous pulsations. Okay, we can see jugular venous pulsations right here in this patient. Okay, so I have inspected the jugular venous pulsations right here. So you can also see pulsations here, but these are due to the carotid artery. Okay, so this one is the jugular venous pulsation. We will inspect, like I said earlier, we will inspect over the anterior border of the sternocleidomastoid and between the two heads of the sternocleidomastoid. And the location of the external carotid is lateral to the sternocleidomastoid. Okay, so this is where we will see the external carotid. Sorry, this is where we will see the external jugular vein. Okay, but we prefer the internal jugular vein. Okay, so now that I have seen the pulsations here, next what I will do is I will take the two scales and the first scale I will place it horizontally, horizontal parallel to the ground, parallel to the horizontal or parallel to the ground, starting at the point of the pulsation of internal jugular vein. And the next one I will place it perpendicular to the ground. Okay, this is not perpendicular to the chest wall. This is wrong. Okay, so this should not be perpendicular to the chest wall. This should be perpendicular to the ground, perpendicular to the first scale. Okay, so this is where I will place it. Okay, and then after I place this, I will take this measurement. Okay, so as I can see here, this is 1 centimeter. Okay, so the vertical height of the top of the column of blood or the top of the pulsation of internal jugular vein is 1 centimeter from the sternal angle. Then we will add 5 to it, so 6 centimeters from the right atrium. Okay, so that is the jugular venous pressure in this patient.
6 centimeter of water.
Yes, so we will report it as 6 centimeters of water. Okay, so why we use the unit of centimeter of water is because the density of blood and water is similar. So, and we are measuring the height of the column of blood, so we will use centimeters of water. We will not use millimeters of mercury. Okay. So we will report it as 6 centimeters of water. Okay. So the normal jugular venous pressure is less than 9 centimeters of water from the right atrium. Okay. So the jugular venous pressure can be increased in certain pathologies. Increased jugular venous pressure with pulsatile nature of the JVP. Okay, increased and pulsatile jugular venous pressure is seen in heart failure.
Cardiac myopathy.
Yes, restrictive cardiomyopathy, constrictive pericarditis, cardiac tamponade, and pulmonary embolism. Those are some of the important causes. And increased but non-pulsatile jugular venous pressure is seen in patients with superior vena cava obstruction. Okay, so if there is an obstruction of the superior vena cava, the pulsatile nature of the JVP will be lost, but the JVP will be increased. Okay, so next we will talk about something known as the Kussmaul's sign. Okay, so we first need to know the alterations of JVP with respiration. Okay, so normally during inspiration the intrathoracic pressure decreases, and then venous return to the heart increases because of the decrease in intrathoracic pressure. Despite the increase in venous return, all of that venous return will be accommodated by the right heart and the pulmonary circulation. Okay, so all of the venous return will be accommodated in the right heart and pulmonary circulation. So the net result is that the JVP will decrease during inspiration. This is during normal. This is the normal physiology. The JVP will be decreased during inspiration. Okay, and in some pathologies like constrictive pericarditis, restrictive cardiomyopathy, and even cardiac tamponade, what happens is during inspiration the intrathoracic pressure will decrease, the venous return will increase, but that increased venous return will not be accommodated in the right heart because there is pathology in the heart, in the pericardium, in the musculature. So there is pathology, so that increased venous return cannot be accommodated in the right heart. So in those pathologies, there will be increase in JVP during inspiration. So there will be paradoxical increase in JVP during inspiration. This is known as the Kussmaul's sign. Okay. So to appreciate this, we need to correlate the JVP with the respiratory pattern of the patient. So that is about the Kussmaul's sign. And there are certain conditions in which the JVP is decreased, like dehydration or hypovolemia. In those conditions, the JVP is decreased. Okay. So next we will talk about some special conditions in which we may need to change the position of the patient. So if the JVP of the patient is grossly elevated, if the neck veins are engorged throughout the neck, then we will not be able to appreciate the pulsations of the JVP. Okay, so we will not be able to appreciate the pulsations of the JVP. So in that condition, we need to increase the angle of the patient. We need to ensure that the patient is more vertical. Okay, so then what will happen is the pulsations will be present in the neck. The pulses will be able to be seen in the neck. Okay, so if the JVP is grossly increased and the neck veins are grossly engorged, to ensure that we see the pulsations in the neck. Dilated. Fully. Okay, so if the neck veins are grossly dilated and we can't see the pulsation, then we will make the patient lie more vertically. We will increase the angle so that we can appreciate the pulsations within the neck, and then we can measure the JVP. If we can't see the pulsations, if the pulsations are inside the thorax or behind the clavicle, then we need to decrease the angle and make the patient more supine. Okay, so that we can appreciate the pulsations within the neck again. Okay, even when we change the position, the method of measuring the JVP is the same. We will again measure the vertical height. Okay, because we are measuring the vertical height, the change in angle of the patient doesn't make much difference to our method of measurement. Okay, so that is about special positions. Then we will talk a little bit about how to differentiate the carotid pulsations and the jugular venous pressure. Okay, so the first thing is the jugular venous pulsations have two peaks, whereas the carotid pulsation have a single peak in the cardiac cycle. In one cardiac cycle, carotid pulsation will have a single peak, whereas the jugular venous pulsation will have two peaks. Okay, and how we will appreciate that is simultaneously measuring the carotid pulsation while appreciating the jugular venous pulsation, or we can also measure the radial artery pulsation, but carotid pulsations are more reliable. Okay. The next one is the nature of the pulsation. So the carotid pulsations are more prominent outwards. Okay. So the carotid pulsations will be prominent outwards, whereas the jugular venous pulsations will be prominent inwards. Okay? So that will be the prominent movement of the pulsations. That is the second point that can help us differentiate. The third point is when we try to palpate, we will be able to palpate the carotid pulsation, but we will not be able to palpate the jugular venous pulsation. We will only be able to see them. Okay, so we will only be able to inspect the jugular venous pulsation. We will not be able to feel them. Next, when we obstruct using our hand just above the clavicle, then the jugular pulsations will be obliterated. Okay. Because the jugular pulsations are caused by pressure in the right atrium. When we obstruct just above the clavicle, then the jugular pulsations will be obliterated, but the carotid pulsations will remain. Okay. So that was the third point. So that was the fourth point. Okay. So next we talked about the changes in JVP with relation to respiration. So with respiration, there are changes in the JVP. During inspiration, the JVP will decrease normally, and during expiration, the JVP will increase. Okay, so this correlation with respiration is not seen in the case of carotid pulsation. The carotid pulsations will remain the same. Okay, so next, changes in relation to the position of the patient. We've talked about that as well. So if the patient is more vertical, then the JVP will move inferiorly. If the patient is more supine, the JVP will move superiorly. Okay, so this change with position is not seen in carotid pulsation. Okay. So next we will talk about change in JVP in relation to abdominal pressure. So if we apply pressure over the abdomen or over the liver just below the right coastal margin, if we apply pressure, then we will appreciate a rise in JVP. Okay. So this is seen even in normal patients. Okay. And separate from this, there is a special sign known as the hepatojugular reflux. The sign of hepatojugular reflux. Okay. So this sign is positive in patients with heart failure. So what we will do is we will apply constant pressure below the right coastal margin over the liver for 15 seconds. Okay. So we will apply the pressure for 15 seconds, and at the end of 15 seconds we will measure the rise in JVP. Okay, so we should have noted the JVP before we did this. Before applying pressure, we should have noted the JVP, and then after 15 seconds of pressure, we will again note the JVP. If the JVP increases by more than 3 centimeters of water, then that is significant. It is positive, and it is seen in patients with heart failure. Okay. So that is all that we are going to discuss about the JVP. Thank you.